All right, welcome to Orsafe.org. This is our second webinar focused on staff safety in the operating room. My name is Alan Brack. I'm the managing editor of Orsafe, a website that's dedicated to promote operating room safety for both staff and patient. This webinar is a follow-on to our first titled Changing Cultural Patterns and Overcoming Resistance to Change. We've chosen Dr. Michael Sinnott for this webinar due to his extensive background in promoting staff safety as a corollary to patient safety. In other words, you can't have one without the other. We thought this interview might have real value for educators and OR staff in defining just what Dr. Sinnott has experienced and where we're going from here. By way of introduction, Dr. Sinnott is both a colleague and a friend for the past 10 years. You'll see a large map behind him. He's sitting in that little pink area toward the bottom in Brisbane, Australia. The voice may come across a little soft, and that's because he has to really yell for me to be able to hear it here in Florida. His academic achievements are impressive. He's associate professor at the University of Queensland in Australia, managing director of ClickSmart Pty Limited, managing director of staff and patient safety.org. He's got 35 years in emergency medicine, inclusive of training of registrars and interns. Many published articles relating to safety of staff. He's been an invited speaker, to name a few, at the AORN, Internal Medicine Society of Australia and New Zealand, WHO's most recent conference, U.S. Annual Conference of Risk Manager, and multiple poster sessions at both the AORN and the American Psychological Society. His impressive CV will be posted on the website for those that wish to fully understand just how much Dr. Sinnott has done to promote staff safety in Australia and abroad. Now that I've listed some of his accomplishments and made him turn bright red, certainly not all, here is Dr. Sinnott.
Thank you, Alan. Good morning from Australia and good evening to you in Florida.
Well, it's at least good in Florida. The rest of the country is buried under 3 feet of snow. So for those of you in Minnesota, you have my well wishes, but I'm glad I'm not with you. Maybe we can start with some simple questions like, tell us a little bit about your background, your experiences with staff and patient safety to begin with in general terms.
I guess it comes from experiences both within medicine itself and from outside medicine. And my experience through ClickSmart and staff and patient safety surprised me insofar as when I looked at a scene that I was usually part of, I saw much more than I did when I was practicing clinical medicine. So as a doctor, I was very enthusiastic about what I could do for individual patient care. Along the training process and with maturity, I worked as a registrar and I was responsible for more patients, the patients I was looking after directly, and also the patients that our junior doctors were looking after. So I was responsible with many other people to make sure that they understood what they were doing and to train them to be better doctors. And I was also, I thought, intrinsically also responsible for their well-being, both psychologically and physically. And when I became a consultant, that role matured and broadened and my responsibilities increased. The next step in my career was to be involved in research because I realised that with research, I could have an influence on patient safety, even more so than I could through direct patient contact and through education of junior doctors. And when I set up ClickSmart, I realised that healthcare is not as safe as I thought it was. In around 2000, the Institute of Medicine based in Washington, DC, published the report to AORN, where on some studies they extrapolated to say that there were probably 100,000 or more preventable deaths in hospitals in America every year. Studies in other countries confirm that. And originally I threw my hands up in the air and said, that's impossible, they were old, they were going to die anyway. But when I looked at it more closely, I realised that what they were saying was very true. Healthcare is potentially unsafe. The Tuera Human stimulated the patient safety movement. And unfortunately, I can remember this from reading the original book, that they talked about focusing on patient safety. And in one line, I think on page 46, they said staff safety would follow. I didn't believe that at the time, and I think over time this has been proven to be grossly incorrect. I think that if you don't have staff safety as important, if not more important than patient safety, you can't improve patient safety. And that's because the mindset of no blame culture for patient safety is it logs to the blameworthiness that staff operate under every day. So I hope that gives you an overview.
It's a good start. Why did you start ClickSmart as a separate entity?
So around the time I was working as a registrar in emergency medicine, and my good friend and colleague, Dr. Neville Henry, showed me a device he'd invented at the request of one of his nurses to take scalpel blades off scalpel handles. I thought it was a great idea and I thought we could commercialise it. So Neville went to Rwanda with the International Red Cross to deal with the
Tutsi Hutsi uprising?
Yes. And I went to Becton Dickinson in America and then Swan Morton in England, showing them Neville's invention. I was told by Swan Morton it was the best scalpel blade remover they'd ever seen, even though they had one of their own, but they didn't have the resources to commercialise it, which I didn't understand at the time, but I do now. So I came home, Neville and I formed a small company with some assistance from government grants. We were able to commercialise Neville's invention. And even though that was just one small step, it opened up the possibility for us to keep staff safe in a number of different areas as well.
Well, my experience with you to date is, although you do run ClickSmart, your interest really is much more benign than just making money on a company. The amount of proselytizing that you do for sharp safety in general and staff safety in general around the world has really been impressive. Do you care to comment on some of the countries that you visited and the reactions that you received to your papers on staff safety and its relationship to patient safety issues?
Thank you, Alan. It's interesting that may be a little bit more difficult for some of the American audience to understand, but virtually all of my medical career was in a public hospital, which is a free hospital. And so we were paid a wage and we weren't charging patients individually. So we sort of had this almost effect that money was almost evil. And it's true that my goal, and as is Neville's in ClickSmart, is obviously to make enough money to employ staff, to invest in more R&D and to invest in the advocacy work we do. But I agree that for me, staff safety is something that should happen. And I see one of my goals as to increase its importance around the world. So the first paper we published was in the British Medical Journal, and it was comparing an ampule opener invented by a registered nurse in Rockhampton and our new sterile scalpel blade remover. And my observations in multiple countries, including America, was the response to the ampule opener was much stronger and much more positive than to the scalpel blade remover. And this didn't make any sense logically, because what these highly trained and highly educated nursing staff were saying was that they were more scared of cutting themselves on a glass ampule than a used scalpel blade. So when we thought about this a lot more, we realised that if I'm a scrub nurse and I cut myself taking off a scalpel blade, I've failed to do my job properly. It's my fault, I blame myself, and I think that's one of the big reasons that 70% of sharps injuries are underreported. But more importantly, because I don't report it, it means there is no opportunity for me or my colleagues or my senior staff to go and look for a safer solution to protect me and my colleagues in the future. Whereas if I cut myself with an ampule, because that injury is so common, everybody blames the ampule. And so originally my first publication to the BMJ, they said I had a conflict of interest and wouldn't publish it. And I wrote back and said, if I had a conflict of interest, I'd be publishing in a surgical journal. This is much more important than this. This is looking at the relationship between staff safety and patient safety, and the ambulator and scalpel blade remover are just a concrete example to make it easier for people to understand, and they went ahead and published that.
As you know, I run around the country giving talks on scalpel blade safety and sharp safety in general terms as it relates to OSHA. When I started doing this 6 or 7 years ago, I would always open the talk with the question, has anybody cut themselves or stuck themselves with a needle? And invariably at the beginning, very few people were really willing to put their hands up and say, yes, that's happened to me. Now I'm seeing almost 40% of the people in the typical audience raise their hand and say, yes, I've either cut myself or I've had a needle injury. That was in the past year or two. And that's been surprising. How do you think ClickSmart or you have affected staff safety over the past 10 years relative to that?
It's almost impossible to measure, but we would like to think that we have had a significant effect, because I know when we would go to AORN, for example, we were the only company talking about staff safety. So we've been talking about staff safety for as long, if not longer, than any other companies I'm aware of. And we've certainly been doing that academically as well. So only yesterday, Marion showed me an article in The Lancet talking about the importance of staff safety, and that's nearly 10 years after our article in the BMJ. And I think that what we've observed in many countries is very similar to what you've seen in America, that once upon a time people were too embarrassed to talk about having a sharps injury because they thought it was their fault. But now I think they're understanding better that they have human rights as well, and that they have the right to a safe workplace. And as part of that, they're more likely to speak up and ask for a safer environment. But I still think at the core, most people working in medicine, be they doctors, nurses, or other allied health professionals, still think that if I take a risk for a patient's benefit, I'm a better person. And so they think that the patient safety is more important than theirs. I disagree. And in my clinical practice, it was always the other way. My staff safety was more important than my patient safety, not by much, but by a little bit. And realistically, you want one safe culture through the whole organisation. So if no blame is the right thing for patients, it has to be the right thing for staff safety as well. And I think that when staff are able to think about risk for themselves and their patients at the same time, we will slowly but surely develop a culture where the whole environment is safer.
Well, we've highlighted in the past on Orsafe, the International Safety Center.org and Dr. Amber Mitchell's work. Can you comment on the current state of affairs as related to EpiNet data?
I think Amber Mitchell and her colleague, who's now retired, Janine Jager, should be applauded for the work they did in helping get sharp safety on the map. And obviously people like Karen Daly, the ex-president of the American Nurses Association, played a huge role in Bill Clinton's legislation. I think that the data they're showing can be looked at in a couple of ways. For example, there is now a 33% reduction in sharps injuries across the hospital, but a 6 or 7% increase within the operating theatres. And so that highlights an area that needs to be addressed. I think the other thing that's extremely important to glean from the data from EpiNet and also from some other international studies, including France, is that we're now starting to record injuries from safety devices. But we're now starting to see that there is a difference between injuries from passive or automatic safety devices, which are the superior ones, than from the active safety devices. So the active safety devices, which are manually operated, cause injuries about 70 times more commonly than the passive safety devices do.
Well, are the organizations such as the AORN or AST and even OSHA, are they doing enough to protect staff? Could there be more?
I think there could always be more. I think the fact that we have so many sharps injuries annually says there needs to be more work done. I think the other organisations that have to help the ones you've already nominated are the bodies that accredit hospitals. So the biggest one in the States is the Joint Commission. And so the Joint Commissions do a very good job going into a hospital and assessing them for patient safety and potential problems with patient safety. But even though they do a little bit for staff safety, they don't do nearly enough. We developed a staff safety score audit or staff safety scorecard, which has been published, which enables a hospital to look at purchasing data as a means of determining whether or not their staff are being compliant with safety devices. And the potential for using purchasing devices to improve staff safety and patient safety is phenomenal.
In a previous webinar that Orsafe has done, we discussed resistance to change, which raised the question, why do we ignore our own safety in the operating room? And I'd like to preface that with a comment that I'm aware of a few OR supervisors who acquired HIV and or hepatitis C or both in the OR. Would you care to comment on that?
Thank you, Alan. I think healthcare tends to be resistant to change more so than people from outside would appreciate. In relation to sharps injuries, we've identified 3 factors, and I've alluded to a couple of them earlier. The first one is denial. As a doctor, I know that these many sharps injuries occur, but somehow I know it won't happen to me, it'll happen to other people, despite the fact I've had a couple of sharps injuries myself.
Right.
The second one is that risk-taking behaviour. I think that most people in my situation believe that if we take a risk for our patient's benefit, we're a better person. It's reinforcing the type of personality that gets you into this line of work. And when I was first qualified, the risks I took were working a longer shift, getting up in the middle of the night. But nowadays, the risk is much more severe. There's permanent back injuries, dealing with obese patients, and the risk of sharps injuries that can give you a life-threatening and lifelong infection. And the second one, which I've also alluded to, is the idea of blameworthiness. If I injure myself, it's my fault. I'm not going to talk about it. I'm not going to look for a safer procedure. And we've published that data with some more information explaining what we've heard and what we've interpreted.
Well, that's interesting that you say that. How can we get champions in the hospital to promote all aspects of safety, not just sharp injuries, but also workplace violence, lethargy, management indifference, money?
I think there's, I think it's multifaceted, and it both looks at supporting your champions and helping them remove the obstacles. And one of the big obstacles that comes up all the time are, 1, we don't have any injuries, and 2, we can't afford to spend this much money on a safety alternative. In answer to the first one, we published data only a year or 2 ago from the hospital I used to work at. 3 years running, we looked at the number of injuries from scalpel blades per 100,000 purchased. And looking at purchasing data is also a new way of looking at risk and looking at benchmarking against hospitals. It's much more accurate than benchmarking on number of staff or number of beds. And we found, I think, that there were 12.6 sharps injuries from scalpels for every 100,000 scalpels purchased, compared to only 2 or 3 for syringes. So that's the first thing. And then when we look at the cost, the problem with investing in safety devices is that the return on investment is harder to measure, because what you're doing is preventing an injury, and that's more difficult to quantify. One of the problems is that nowhere in a hospital budget does the cost of an injury occur. For example, Alan, if you were unfortunate enough to have a sharps injury, then you would leave the operating theatre. So there's a cost to the operating theatre because your case may need to be delayed or cancelled. If you come down to the emergency department, so emergency department time would be involved. We'd be taking bloods from you. We'd be organising for bloods to be taken from the patient, so there's a cost to the patient. Then you would be going to infectious diseases and having blood tests in 6 weeks, 6 months, and potentially in 12 months' time. Plus or minus the prophylactic or treatment cost that would be added to that. That's not trapped in one budget. So we developed a value analysis calculator that enables you as an individual, or you as a hospital manager or purchasing officer, to enter the data that you're aware of for your own hospital into this calculator. All the formulas are transparent, and when you come to a question that you don't know the answer to, then we'll give you a range of choices based on published literature. And again, all the literature is referenced. At the end of the day, it gives you information about how much money you're spending on standard equipment, how much money you would need to spend to make your, for example, operating room safe. And we're looking at legal requirements here. So how much money would it cost you to convert to safety scalpels, or how much money would it cost you to change to scalpel blade removers and single-handed hands-free passing techniques. And it also tells you how much money you're probably spending, unbeknownst to yourself, managing the complications of these injuries. And then it's quite simple to tell you how much you invest to how much you save.
That sounds a little bit like the tip of an iceberg scenario.
I think that's a very good scenario, Alan.
Just out of curiosity, is there a cost to that particular piece of software that you're talking about?
No, it's being developed in-house, and it's made freely available on the digital platform that ClickSmart has. So staff and patient safety have been involved scientifically, but the tool's made available for people to use free of charge. And the other thing, because it's online, it means it's available 24 hours a day, 7 days a week. And as a now happily retired shift worker, it means that if I'm working the operating theatre, if I've got an hour free, no matter what time of the day or night, I can use that time to go onto the website. It doesn't mean I have to wait for an expert to come in and teach me. And especially during COVID-19, when those experts aren't allowed to come in and speak to me, it gives me, as the clinician, more autonomy and more control about how I manage my risks.
You mean you don't like to get up at 4 a.m. from a cot in the back room somewhere to come out and treat somebody from drinking too much?
It's one of those things I only pretend to miss.
Okay. What about the paradigm we started talking about earlier? I'd really like you to expand a little bit on the equation of patient safety and staff safety being equal, rather than, when I wander around the average hospital, there are signs everywhere talking about patient safety and what you should do if you see somebody wandering about lost. But I rarely see anything for staff safety other than perhaps in the employee health room, which 9 times out of 10 is a small room in a basement somewhere with the dripping pipes overhead.
I think for me, it just became natural. So when I was the registrar or the consultant in the emergency department, and I had a relatively large number of junior doctors and also the nursing staff as well, who I was responsible for, as well as the patients, it seemed pretty obvious that my colleagues, the staff, who were almost friends in many respects, their safety was my primary importance. So I was responsible for making sure that all the patients got the best treatment they could, but I didn't want staff being sick, I didn't want staff being injured, I didn't want staff being abused by other staff, by patients or relatives. And I always thought it was my job to step in and sort that out. And then when you think about it externally, I remember I was in Washington, DC, speaking to one of your federal government House of Representatives who was responsible for worker safety. And I was explaining the statistics to him, and he said to me, how many sharps injuries are we talking about? I said, it's probably 3 or 4 million every year in America. And he literally nearly fell off his chair, because there aren't any other industries that I'm aware of that would accept that number for their staff. And so I think the next step is, in logic, is that if a staff member is injured, they can't look after the patient. But I think the next level up is much more important, that I can't see anybody having 2 different rules for safety in their head and being able to function appropriately. Having to look at one class of people, namely themselves, and say their safety doesn't matter, but all of a sudden the safety of patients does matter. Surely it makes more sense that safety across the board is important. Safety for the medical staff, safety for the wardies, safety for the clerical staff, and safety for the patients. Sorry, I get a bit passionate about that.
And rightly so. My experience with you is it's always been you're passionate about these issues. Do you think OSHA needs to be more proactive in dealing with hospitals other than just coming in and looking at back injuries?
I remember I met with, it would be the equivalent in Australia of a minister. So who's the top person in a government department in America?
Well,
Secretary?
Yeah, secretary.
So I met with the secretary of OSHA many years ago, and he explained to me that OSHA already had a memorandum of understanding with the Joint Commission and a third body that I've just forgotten at the moment. So there is the possibility for those bodies to work together, but it doesn't happen on a day-to-day basis.
As well,
So
CMS.
Sorry?
CMS.
Thank you. And so I think that what OSHA could do to improve their efficiency and effectiveness is to start to look at some of these more objective scores, as I referred to before, the staff safety scores. So at the moment, if I'm an OSHA reviewer, I might go into a hospital and look to see if you're using safety syringes or you're using single-handed blade removers, but you can pretend while I'm there. Whereas if I just say to the purchasing department, tell me how many syringes you bought, how many safety syringes you bought, and then I can work out whether you're taking this seriously or not. How many scalpels did you buy? How many scalpel blade removers did you buy? Because we know that if you don't buy a scalpel blade remover, you don't use it. And on the same token, we do know from first-hand observation that some hospitals and some private doctor surgeries would buy a box of safety syringes and leave them on the shelf and never use them. So if you look at your purchasing data, you're only going to buy more safety products if the ones you bought earlier in the year have been used and you're replacing them. And so I think OSHA is very hampered by their lack of resources, but I think there is some technology now available and some ideas now available that would make them much more effective. And I have no doubt with the people I've met from OSHA that their passion for this is very strong.
I certainly agree to that, having talked to a number of OSHA offices. Unfortunately, there's a limited number of inspectors that actually go out. And they have limited time on what they can actually look at. So
I think that's, sorry to interrupt, Alan, I think that's why the idea of looking at purchasing data saves them time. They can, that's simple. The facts are in front of them, they don't have to go and observe it. And the time they save on that, they can spend looking at other important issues.
No, absolutely. All right. Well, this has been great. Perhaps sometime in the future, you could come back and we can go into greater detail, particularly based on EpiNet statistics. And they certainly are a useful resource for any nurse educators on some of the issues out there in the way of sharps injuries, amongst others, such as back injuries, lethargy, loss of interest in the job, on and on and on. If you're available.
Thank you for the invitation and thank you for your time today. I'd always be very happy. So if your viewers can think of a topic, then I'll be very happy to share my experiences, and I'd also be very happy to update my knowledge on the latest published data as well.
May we put your email address on the base of this talk?
Absolutely. I'm very happy to give you both the ClickSmart email address and the staff and patient safety email address. I can then respond to in whichever way you would like me to respond.
Before I let you go, could you just describe quickly what is actually on the staffandpatientsafety.org website?
The staffandpatientsafety.org website was set up to be more academic. It was to share the results of our research and other relevant research around the topics both of sharp safety and also the topic of psychological safety, which is better known now as well-being. And what we wanted to do is present the facts separate to the ClickSmart sales message as well, so that people could feel that the information on staffandpatientsafety.org was more neutral. And obviously my and Neville's potential conflicts of interest is stated on that website.
Would you recommend the website to nurse educators?
Yes, and the nurse for the nurse educators, I think there's a lot of very important material there. It's being updated as we speak. But the other thing I would recommend for the operating room nurse educators is to look at the digital platform on ClickSmart. The information there is really, really very impressive, and I think it would be very helpful.
Okay, well, again, thank you very much for taking part in this webinar, and we'll certainly have you come back. Future webinars will cover areas such as smoke and malignant hypothermia, just to name a few. Thank you all for viewing this webinar. I look forward to the next one, and I'm always looking for outside input on topics you may wish to have discussed. Have a good day. Thank you.